welcome to today's clinical question time case study. Now today's case study revolves around the theme of hypertension and antihypertensives. So let's crack on with it. So 68-year-old Mr. BP is admitted into hospital for a fall. You are conducting a medicines reconciliation and note the following on the front of the chart. Case study goes on, Mr. BP tells you he has been feeling quite faint in the morning, but for the last week it has been especially bad. He made it to the toilet this morning but embarrassingly fell and his wife had to call the ambulance. He goes on to tell you his cholesterol hasn't been well controlled and was meant to see his GP Dr. Lipid but hasn't had a chance yet. Identify the 2 drug therapy problems present. Now the first thing we need to do is screen the actual drug chart and get an idea of the different details and what's important. So the top of the drug chart has the patient details. So we've got the patient 68 years old, so they're elderly. Sometimes they briefly classify elderly as over 65 years, but you have to take into account other things. But that's what, if you look for the age just on its own. So we've got that the patient's been admitted into A&E. We've got that they've got no known drug allergies. We've got the weight and the height. So we can actually work out the BMI, the body mass index, which is good to know how to calculate, which is kg over meter squared, which is 85 kg. And divide that by, we've got to convert the centimeters into meters, so 1.77 meters squared. So we need to square that. And that leaves us with about 27.1. So they're in that category of overweight. Overweight is classified as between 26 and 30. And that can have an impact on certain diseases that the patient may suffer from. So what I normally do is I'll look at making a timeline for drugs on admission, because it just helps you get an idea of, okay, is there any medications that the patient's on that's unnecessary? Are there any medications that had an impact on why the patient's admitted or why they're on the ward? And it just makes it a lot easier. So the drugs on admission, so they're the drugs the patient brought on with them. So we've got that classified into date, in brackets duration that they were on the medication, the name of the medicine, and what they're using for, the indication, the dose and the frequency. We've got change in therapy since admission if applicable, but they've just been admitted, so there's not been any changes. We'll start with the first medicine they were on, so that's 12 months ago. And that's losartan. It's 100 milligram that they take every morning. That's money. And they're using that for hypertension. Next, we've got 8 months ago. And they were started on felodipine. Started on 10 milligram every morning. That was also for hypertension. Next, we have 5 months ago. And they were started on simvastatin, 40 milligram every morning. And they started on that for high cholesterol or hyperlipidemia. And then finally, 2 weeks ago, they were started on doxazosin, 4 milligram every morning, and that's for BPH, benign prostatic hyperplasia, that's enlarged prostate and hypertension. So we've got that to refer to now, and it makes it a lot easier. Now we need to look at any important clinical information that's been given to us. So that might be any bloods or any vitals. So we've got the blood pressure, which is 89/62. So that's actually quite low. So I'd put that down there. Normally if it's the systolic's less than 90, or the systolic and diastolic's less than 90/60, then that's quite low, their blood pressure. And they're probably at risk of falls and post-oral hypotension. The pulse is 63 beats per minute, which is on the lower end. Resting heart rate's normally between 60 and 100 beats per minute. So they're right on the low end, and normally only patients that are like athletes or maybe those that meditate a lot. Those sort of patients may have a low heart rate compared to a normal patient, but I don't think this patient's an athlete. You've got a temperature of 36.8, that's normal. We've got a serum creatinine of 80 micromoles per litre. So we can combine that with their age and we can actually calculate their renal function. So creatinine clearance is, for a male, it's 1.23 R factor, for a female it's 1.04. Now creatinine is normally broken down by muscles, and the rate at which it flows through in the kidney, that can help us to determine the renal function. So 1.23 times 140 minus age, which is 90, age is 68, multiplied by their weight, which is 85 kg, divided by serum creatinine, which is 80 micromoles per litre, and creatinine clearance is always in mil per minute, so that gives us about, I'm just putting this in my calculator, 94.1 mil per minute. Now normally if you're working glomerular filtration rate in terms of creatinine clearance and not estimated glomerular filtration rate, the categories for severe, moderate and mild renal impairment are, you've got less than 10 mils per minute, that's classified as severe, 10 to 20, that's classified as moderate, 20 to 50 is classified as mild, and everything above that's normal. So this patient's renal function is actually really good for someone that's that old, because as you age, renal function deteriorates by some degree anyway. So we know the patient's got poor renal function. The patient's got good renal function. The main things are the low blood pressure at the moment. So we've got a cholesterol profile. So total cholesterol is 6. Now total cholesterol should be normally less than 5 millimoles per litre. LDL is 3.4. That should normally be less than 3. And HDL, which is high density lipoprotein, is 0.8, which should normally be more than 1, which is our good cholesterol. So we can tell that that marries up with what they've actually been saying to us, that his cholesterol hasn't been well controlled and he's meant to see his GP. So cholesterol is not good. Compliance aids, then that's not applicable. They don't take any dosages or use any medication aids. The patient manages their medicine themselves, and we've got once only or pre-op drugs, but that's not applicable at the moment. So the most important thing we want to look towards is why they fell in the first place, and see if it's related to any medications or anything else. So the patient was started 2 weeks ago on an antihypertensive, and the last one antihypertensive before that was 8 months ago, and their blood pressure is actually really low, so it's likely that they're suffering from post-oral hypotension, which is that phenomenon. I don't know if you've ever felt like when you stand up really quickly you feel dizzy for a few seconds and then you feel okay after. That phenomenon is known as post-oral hypertension, which is hypotension, so low blood pressure, due to posture change, post-oral. And that's why the patient may have fell. So when an elderly patient falls, there's risk of fractures, and one of the common ones being neck of femur fracture and hip fractures. So it's something we'll want to avoid, because there's lower bone mineral density as a patient ages, and it will be really bad for quality of life and so on. So now it's good that we understand the pathophysiology of post-oral hypertension, and so I'm going to go through that now, because this is likely to do with our first drug therapy problem. So first of all, we need a backdrop on some of the blood vessels and the nature of them in our body. So we've got arteries, arterioles, capillaries and veins. So I'll quickly draw the network for you. So normally you start with arteries. So arteries pump blood away from the heart, and they have high pressure because the heart has to pump blood all the way to the rest of the body. Next you have these arterioles, which branch out from the arteries. Now then you have capillaries, and capillaries are like the thinnest vessels in the body, and they normally exchange oxygen and nutrients for carbon dioxide and waste material, and it normally occurs near the tissues. And then finally you have the veins and venules, and these take blood back to the heart, and they normally have a low pressure. Now, as you can probably note, the blood pressure decreases as you go from arteries to veins, so that's something to bear in mind. Now, gravity is one of the single biggest physiological stresses on the body, especially on our cardiovascular system, and so it's important to look at. Now, the only exceptions when we're lying down. When we lie down, gravity is acting equally across all parts of the body, and so the blood pressure specifically is exclusively due to the pumping of the heart. So if we reflect this in terms of pressure in the different vessels, you've got 26 mmHg approximately in capillaries near the head, and so you've also got 26 mmHg in capillaries near the feet. And in arteries, the blood pressure tends to be about 90 mmHg, and in veins it tends to be around about 15 or so. So you can see there's quite an even spread. Now let's look at if we stand up. If we stand up, gravity is pulling blood down from the head down to your feet, and so the pressure is higher at the feet than it is at the head. So this creates a problem. Well, why does it create a problem? Because the blood's actually being pulled away from the head, and so what that does is it reduces what's called venous return. Now, say you're trying to pump blood back to the heart through the veins. So the veins are actually acting against gravity because they're trying to push that blood back up to the heart, and gravity is trying to push it back down. So that means you have a decrease in the total volume of blood that's going back to the heart. So when the heart relaxes, the ventricles fill with blood, and that's called end diastolic volume. So that's just before they're going to contract, the chambers fill with blood. So you have a reduced end diastolic volume. What does that mean? Well, that means you're going to have the total amount of blood that's pumped out by the heart, because less fill in the ventricles, is going to go down. So the total amount of blood pumped out the heart per beat is going to go down. That's called stroke volume. So stroke volume goes down. What does that mean? You have a decreased amount of blood that's pumped out of the heart per minute. So stroke volume with heart rate forms cardiac output. So if you decrease stroke volume, you decrease cardiac output. Now what does that mean? Well, blood pressure is made up of cardiac output times peripheral vascular resistance. So if you decrease cardiac output, you're going to decrease blood pressure. So if you decrease blood pressure, the pressure may not be high enough to actually get a sufficient flow of blood into the brain. So you have a decreased cerebral blood flow. So what's going to happen is you're not going to have enough oxygen which gets to the brain, and that means you're going to start feeling dizzy, and then you may even suffer syncope, which is fainting. And what happens is, that is what we call postural hypertension. Now, the body actually has a natural homeostatic mechanism where, if appropriate, it triggers. So it happens at a pivotal part of the process, and that's actually when the blood pressure actually decreases, and it activates certain receptors. It activates receptors found in the aortic arch. That's the greatest abundance, and there's some found in the carotid artery, but mainly in the aortic arch, and these are called baroreceptors. Now these baroreceptors, they're mechanoreceptors, and they sense changes in pressure, in blood pressure in the vessel. So as you can see, you've got these receptors, and they sense any pressure. and changes in pressure, if they find, for instance, the blood pressure is going down, then they'll activate what's called the baroreceptor reflex. And what the baroreceptor reflex does, because it sends a signal to the cardiovascular reflex center, and that basically increases contractility, which is how hard the heart squeezes per beat. It increases heart rate and it increases vasoconstriction. Remember, blood pressure is equal to cardiac output times peripheral vascular resistance. So if we actually increase the heart rate, cardiac output is actually made up of stroke volume and heart rate. So heart rate being beats per minute. So if it beats more per minute, you're going to get higher blood pressure. If you increase how hard the heart squeezes per pump, imagine you've got a sponge. If you squeeze it harder, more water comes out. Heart's the same thing. If you squeeze it harder, more blood's going to come out. So that's going to increase the pressure. So you increase blood pressure. And finally, vasoconstriction. If you actually look at peripheral vascular resistance, that's vessel resistance to the flow of blood in peripheral arterial vessels, and that's typically a function of the vessel diameter. So if you make the diameter, say, smaller, then that means there's going to be higher pressure, because imagine you try and blow for a straw. Now, if you blow for a straw, it's hard, and you put your finger on the end, it's harder to blow through. But if you blow through a pipe and you put your hand on the end, it's actually easier to blow through. So it's going to be like you're blowing through a straw, like in the heart. So the blood pressure is obviously going to go up. If you can't imagine it visually, then peripheral vascular resistance, if it goes up, then blood pressure is going to go up. So all of that, all in all, is going to increase blood pressure. Now, what that means is if you have an increase in blood pressure, that means you're going to have an adequate and sufficient blood flow that gets into the brain. So adequate cerebral blood flow. That means you're going to get adequate oxygen that gets into the brain, and that means you're not going to get that dizziness and you're not going to get that syncope. Now, sometimes when we look at that homeostatic response, it actually takes seconds. Now, I'm going to quickly go into something on a side note for any of you that do first aid training as part of your clinical course. But when your body actually falls over, that's actually another homeostatic response. Your body actually falls over on purpose. Now, remember, when you lie down, gravity is acting equally across all parts of the body. So the pumping of the heart's exclusively, what's causing the changes in pressure. So if you lie down, that means the veins aren't acting against gravity to get blood back to the body and back to the heart. What's happening is you don't have that antagonistic action. So that means venous return is sufficient to get blood back to the heart, and so you have that sufficient end diastolic volume, you have that sufficient cardiac output, you have that sufficient blood flow to get into the brain, and you have sufficient oxygen, so it helps get back into that. And that's why if a patient feels dizzy and you think it might be because of low blood pressure, then what you'll do is you tell the patient to lie down. Now, say you wanted to compound that effect, you tell the patient to lift their legs up, or for you to pick their legs up, and make sure it's above the chest height. Now, why is that? Because now you're making gravity work in your favor, because gravity is actually pushing blood quicker to the heart. So you've got an even higher venous return. So there's more blood returning through the veins to the heart. So that increases end diastolic volume, the amount of blood that's filling in the chambers at the end of diastole. You're going to increase stroke volume, total amount of blood being pumped out of the heart. You've got an increased amount of cardiac output, total blood being pumped out of the heart per minute. And that means you've got increased blood pressure and you're getting sufficient flow to the brain. And hopefully the blood pressure will pick back up. Now, if we decide to look at, what sort of things act to impair the baroreceptor reflex, then we know that those things are what leads to post-oral hypotension. So there's actually different factors, and that's why some people are more likely to suffer post-oral hypertension than others. Now, if the homeostatic response is slow, so that baroreceptor reflex is slow, then rather than taking seconds, it will take a bit longer. And if it takes too long, then, like, you know, a patient might fall over or they might get dizzy and faint. Now, elderly patients, they tend to have a slow baroreceptor reflex. So as we age, our baroreceptor reflex actually slows down. So they're more prone to getting post-oral hypertension. Now also, patients taking antihypertensives, if you think about it, if you have a lower down baseline blood pressure, it's going to be harder because you're working against that, you know, that you're trying to vasoconstriction, you've got a vasodilation action occurring, or you know, you've got a lower heart rate and you're trying to increase the heart rate to get that pressure back up. So antihypertensives as a general class, they actually slow down the baroreceptor reflex, or they impair it. So it's actually harder for you to get the pressure back up. So you're more likely to suffer post-oral hypertension. And it's especially, you know, potent with certain antihypertensives. Now, finally, we're going to look at something that exacerbates post-oral hypertension, which is heat. Now, having heat, if someone has a fever that occurs, or, you know, it's a really hot day, it can cause thermoregulation, where reflex cutaneous vasodilation, that can actually increase flow to the skin, you know, so we get that perspiration. But remember, that actually has an effect on peripheral vascular resistance. So having that increased vessel, that's actually going to reduce peripheral vascular resistance, because remember, that vessel's getting wider, so the diameter is getting bigger, so the peripheral vascular resistance goes down. So if that happens, that means our blood pressure is going to go down, and that means that we may not get sufficient flow to the brain. If you don't get sufficient flow to the brain, then you might get that post-oral hypotension. That's why sometimes you hear about people fainting in the sun, because it's being antagonistic against the baroreceptor reflex. We're trying to trigger it, but, you know, this vasodilation to this reflex, cutaneous vasodilation to the skin is happening. So that's why you might hear that people feel dizzy in the sun, and it may be because of low blood pressure. Now, let's come and apply this to our drug, doxazosin. Now, doxazosin's what's called an alpha blocker. Now, these drugs actually bind to receptors on blood vessels, and these receptors actually are called alpha receptors. Now, normally, norepinephrine, which is a neurotransmitter, actually binds to alpha receptors, and normally that causes vasoconstriction. And vasoconstriction causes a decrease, causes an increase in peripheral vascular resistance, which causes an increase in blood pressure. So if we get an alpha blocker, it actually antagonizes, so the norepinephrine cannot bind, so it antagonizes those receptors. And certain alpha, you've got non-selective alpha blockers, and you've got more selective alpha blockers, and doxazosin's more of a selective alpha blocker, specifically working majority on alpha-1 adrenoreceptors systemically. Now, if you have norepinephrine which binds, normally it gives this sympathetic nervous system response, and norepinephrine is normally released by sympathetic nerve endings, and so as an antihypertensive, it impairs the baroreceptor reflex. So alpha blockers are going to impair that baroreceptor reflex, and alpha blockers are especially potent at first dose post-oral hypotension. So that means patients are likely to, you know, feel dizzy if they get up too quickly. And so if we take it back, we're impairing that baroreceptor reflex, and we take it back to our original question, we can see that the blood pressure is less than 90/60. Now, the drug was started 2 weeks ago, so this solves our first drug therapy problem. So it's a good idea to bring this up with the clinician and say, oh, maybe the doxazosine, it was started 2 weeks ago. It maybe have caused the low blood pressure, and that's why the patient might have fallen, and it's something to think about in the future. Now, you be careful, because you need to think about a potential alternative, because the patient's not just using it for blood pressure, they're also using it for BPH. So you may change it and say, okay, we'll put them on a different antihypertensive, but alpha blockers have a dual mechanism. So what they do is, as well as being found on systemic blood vessels, they're also found in the bladder, neck and prostate of the urinary tract. Blocking those receptors actually help really relax smooth muscle there, like the detrusor muscle, which is specifically which is a bladder muscle, specifically the neck of the bladder. So it helps with the urine flow. That means it can be used in benign prostatic hyperplasia, where you've actually got, say this is the bladder, and this is your urethra. You've got a prostate, and it's actually enlarged and it's pressing against the urethra. The more urine's staying in the bladder and it's not flowing out properly. So you get that incomplete bladder emptying. You may get what's called, quote, dribbling, where the patient doesn't feel, where only a little bit of urine's coming out per unit time. So alpha blockers work to block those receptors, so it helps with that. So you have to make sure you give a medication that will also help with their BPH, as well as, anything else that the clinician wants to put on. But this patient may actually be okay just being taken off the antihypertensive, but you'd need to monitor the blood pressure and see how they get on. So that's our first drug therapy problem solved. So going back to our second drug therapy problem, we know that the patient's taking simvastatin. Now, if you look, the patient's taking 1 tablet every morning. Now, if you know the pharmacokinetics of simvastatin, the elimination half-life is roughly about 1.9 hours. And that includes some of the active metabolites of simvastatin. So that means that the patient may not be getting full effect, because most cholesterol is made when our dietary intake is low, and the time that our dietary intake is lowest is at night. So that's when it will have the best effect. So really, this patient needs to be taking the simvastatin at night, because the plasma half-life isn't enough to give an optimal effect. And we can tell by their cholesterol, because it's a bit high, and their HDL is not high enough. So that's something we can optimize and let the clinician know that. So that's our 2 drug therapy problems solved. Let's move on to our second part of the question. While sorting out Mr. BP's drug therapy problems, he asks if he can have a word with you in private. He goes on to tell you he's having embarrassing issues when making love to his wife, which started a few days ago. Specifically, he tells you he's not ejaculating when he wants to and asks you for advice. So the patient's probably not orgasming properly. Now, during ejaculation, you have increased alpha receptor activation, which actually closes the bladder neck, facilitating normal flow of semen out the penis. So say like this is your bladder. You've got this area here, which is known as the seminal vesicle. And then, sorry, it's a bit of a bad drawing. And this is the urethra. So this is a zoom in version. Normally what happens is, this is the bladder. this sphincter circutudinal muscles at the bladder actually close during ejaculation, and that allows the path of least resistance is then passed through the urethra here, because obviously this is closed anyway. So when the patient ejaculates, the semen then comes through and goes through the urethra. Now, if you use an alpha blocker, or it's disrupted, say we're relaxing the bladder, this to allow urine flow, then this is going to be relaxed. It's not going to be, the muscles aren't going to be close together. So what that means is the semen can actually go into the bladder. So that's the path that's least resistant. So what that means is the patient's going to get retrograde ejaculation, where the semen enters the bladder instead of emerging through the urethra. Now, this type of sexual dysfunction's quite rare, and it's not that common with alpha blockers, but there's a risk it can happen. And it tends to happen, if it does happen, it happens with alpha blockers that tend to work less systemically, such as tamsulosin, but it can happen with others. Now, the effect is reversible, and it can even be alleviated by dose reduction. Now, the patient's probably going to be coming off the doxazosin, but you can, if for some reason they decide to, reduce the dose or something, then that's something that you can bring up. And normally what happens is if the semen goes in the bladder, certain symptoms, maybe they get cloudy urine because it's in the bladder now, or they may get what's called a dry orgasm, so they don't get an orgasm at all. Well, that wraps up today's clinical question time, and obviously leave comments. If you have any questions, then just let me know, and I'll see you next time.